When a patient dies from an overdose, the prescriber has some potential liability there, and the extent of that liability, meaning whether it's going to be a licensing board issue, a licensing board plus malpractice, or even worse, a criminal case, really depends on the nature of that provider's care. In other words, the story that they've written with that patient throughout the time that there's been that provider-patient relationship. They're looking for things like proper evaluation, proper prescribing, control of drug supply, acknowledgement of risk issues, stratification, and handling that person according to a properly evaluated risk profile, low or high risk, for example. They're looking for acknowledgement that with some patients, high doses may not be the right thing. They're looking for acknowledgement that with some patients, a combination of medicine may or may not be the right thing. And all of that plays back into what caused the overdose. What does the information from the coroner actually say? And so there's a large examination of the individual patient file, but then there's a even broader examination of the habits in the prescriber's practice. And so they should write the story now and really be careful to tell that individual tale and treat people that way. And that may really guide and make a difference between simply getting a sanction letter and going to jail. I think prescribers come up short in risk mitigation when they prescribe chronic opioid therapy, when they don't really acknowledge that perhaps their EMR or charting system isn't working for them well. They may do what they perceive to be individual compliance steps with their licensing board requirements. They may think that they've done a good job of evaluating risk on the front end. But when you look and do a deeper dive, you see kind of disjointedness. You see use of risk assessment tools that maybe are scored but are never carried into an overall risk evaluation. In other words, you might have scored a SOAP R and figured out that the patient was low risk, but you didn't look at the risk associated with potential overdose event. Sometimes that's an EMR issue, sometimes it's a template issue, but that's one of the big areas where providers miss the boat. The other area is carrying through on the MME measures, the morphine milligram equivalents. Some states are more strict about that, and the provider should have a mechanism for capturing that. And I think the third big thing is they don't really have a good dashboard to work from. They don't, a provider only has so much time, and if their EMR system or charting system doesn't bring that back up in front of them at the time of the encounter, or doesn't have a good way of warning them that something's amiss, they miss it, and they don't pull it all together because they simply don't go back and look at the entire chart before the visit. I think that's very unusual. So they miss the boat on that, and that can add up to big problems over many patients. And I think most providers try to do it right, but the system in the charting can work against them. It's become quite burdensome, and we need to provide them with better tools, dashboards to track these things. When a provider is a subject of a licensing board inquiry, the first thing is take it seriously. Don't ignore it. Some people do. They'll set the letter aside and they won't answer it. There's actually a deadline in that letter. The next thing that I think a provider should do is probably consult counsel, especially if there's a death allegation in the licensing board's letter. Normally they'll tell you that up front. And the lawyer can help you framework your response. We've had a lot of experience helping providers write responses to licensing board letters, going through the file, really having them look at it objectively, and then working with their local counsel to provide a response that shows the provider's humble, they understand their obligations, and they're not there blaming it on other people. They're giving a good, concise, factual summary of what happened. And the lawyer can also help massage over some of the more difficult facts where maybe the provider overlooks something like that. We had one of those earlier this year, and it turned out well for the provider. But I think it's because the provider really did take the notice seriously. She did a good job in her care of the patient. The patient wasn't telling the full truth. and some of the drug testing that was being done wasn't really up to speed or up to par. It wasn't as good as it should have been on the front end, and that wasn't the provider's fault. You're starting to see across the country efforts, for example, in California, where licensing boards and other authorities are examining overdose deaths. And it's my understanding that they're trying to differentiate an opioid overdose death coming from prescribing of opioids from a street opioid or heroin overdose, and even from a suicide. And I think that's super important because so much is being heaped on the shoulders of chronic pain management professionals and patients. It's a bit unfair when you do overdose litigation like we do. We see the differences. We sometimes have to argue those differences in court, and I think it's a really good thing that this project's being done. I think it will result in some changed statistics and perhaps even a sharper look at the unintended consequences associated with blaming everything on chronic pain management when you start to see some of these suicides and you start to see some of these things that are really street drugs like heroin that has nothing to do with the prescribing.